Welcome everyone and good afternoon. My name is Caitlin Bafis-Lasky. I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm pleased to welcome you all today to our webinar on the importance of understanding your lymphoma subtype. As you may already know, lymphoma can be an umbrella term for many different lymphoma subtypes, and each subtype of lymphoma can have its own clinical course, which means that each subtype can have its own specific set of symptoms, diagnostic testing, staging, prognosis, and possible treatment options. It's therefore very important to understand what your lymphoma subtype is when you're diagnosed, as this can help you with your education and understanding, with setting appropriate expectations throughout your lymphoma care, and can also help you connect with others that are diagnosed with the same subtype. We appreciate so many of you joining us live today to learn more about lymphoma subtypes and the importance of understanding your diagnosis. Now, before I go ahead and introduce today's speaker, there are just a couple of items to note. This webinar is being recorded and it will be posted on Lymphoma Canada's website later today. You will also receive an email by the end of the day today with a link to watch the recording. We have left some time for questions at the end of this presentation. So if you have anything that you'd like to ask either during or following the presentation, you can type your questions into the questions box, which is located at the bottom of your control panel on the right-hand side of your screen. And we will try to answer as many questions today as possible. I would now like to take a moment to introduce and welcome today's speaker, Dr. Anka Parikh. Dr. Parikh is a staff hematologist at the Mount Sinai Hospital and Princess Margaret Cancer Center, and she is currently the site lead of the Lymphoma and Myeloma program at the Princess Margaret Cancer Center. She has a master's in health research methodology at McMaster University with research interests in quality of life and economic evaluations. Her clinical work focuses in both lymphoproliferative and plasma cell disorders at both hospitals. She dedicates her work and research to the malignant lymphoma patient population, and we are very excited to welcome her today to share with us more information about the importance of understanding your lymphoma subtype. I would now like to turn over the presentation to you, Dr. Parikh. Thank you, and take it away.
Great. Thank you so much for having me and asking me to speak on this really important topic in lymphoma, especially when first diagnosed. So a couple of the objectives I'll try to sorry about that. It looked like the video just. So a couple of the objectives I'll get through today are to define some of the subtypes of lymphomas, diagnostic testing and staging, discuss the most common types of lymphoma, and I'll give you examples from aggressive versus indolent lymphomas comparing to Hodgkin lymphoma, and how that might differ in terms of the diagnostic pathway as well as treatments and prognosis, and why it's really important to really know what subtype of lymphoma we're treating. And finally, answer any of your questions. For a little bit of background, the lymphatic system and what leads to, or the part of the body where lymphoma develops, is a network that's made up of a number of pathways through the body. So that it can be made up of the lymph nodes, the lymphatic vessels that can connect these lymph nodes, and there are organs in the body that we consider as part of the lymph system. So that would be the bone marrow, the thymus gland, which is in the front of the throat, or upper part of the chest, and this is something that is more important in early adulthood, where it produces lymphocytes, and as people age, becomes less and less important, but can be involved in the development of lymphoma, tonsils, spleen, liver, and there are lymphocyte cells in the lining of the gut, the lungs, and other parts of the body that we may not traditionally think about. So what are lymphomas or leukemias that involve the lymph system? These are cancers that develop from the cells of the immune system and of the lymphatic system that I highlighted in the previous slide. So it can be a cancer of the lymph nodes, so involving the lymph nodes, the spleen, the bone marrow, and can have a leukemic phase. And leukemia really just means that there are white blood cells circulating in the blood that can be picked out. So although we think about when we hear the word leukemia, it's usually associated with a much more aggressive subtype involving other parts of the blood system. If there are lymphoma cells in the blood, the subtype might still be defined as a leukemia, and an example would be chronic lymphocytic leukemia, which is actually more lymphoma-like. Lymphoma is the fifth most common cancer amongst tumor subtypes, and its incidence has been increasing over decades. In Canada, this is data from a few years ago, there are approximately 9,000 new cases per year, and as you can see here, they're divided into two large subgroups, non-Hodgkin lymphoma and Hodgkin lymphoma, with non-Hodgkin being much more common, about 8,000 cases new cases per year versus about 1,000 Hodgkin lymphoma patients. And you can see here some numbers, how they're broken down by in males versus females, and how many people die from these lymphomas every year. There are some risk factors, although we don't traditionally think that there are very certain risk factors that can lead to its development, a link such as that's more common, for example, smoking and lung cancer. We don't have such linkages in lymphoma, but there are some predispositions. So autoimmune disorders can predispose to particular lymphomas developing, for example, in the gut, so celiac disease or Crohn's disease. Sjogren's syndrome is a type of dry mouth syndrome, and that can lead to a low-grade lymphoma developing in the salivary glands, for example. Some viruses have been associated with lymphomas with a predisposition, so things like HIV or hepatitis C. H. pylori is a bacteria that can cause ulcers in the stomach, and it has also been associated with a low-grade lymphoma. And patients who are immunocompromised, so who have had, for example, organ transplant, such as a lung transplant or a liver transplant, get a particular type of lymphoma called post-transplant lymphoproliferative disorder. And usually we know well in advance, of course, that they have this risk factor when it occurs. Thus, lymphoma as a type of cancer comprises of more than 50 different types, and probably even more being subdivided as we speak. So really the treatment of a patient depends on the type of lymphoma, where it is located in the body, as well as age and general health. And this is not to go through every single one in detail, but just to highlight what I just mentioned in the previous slide, that on the right here, you can see all the different types of lymphomas or lymphoproliferative disorders that are classified by the WHO classifies all tumors, and there's a book or a publication looking at tumors of the blood and the lymphoid tissues, and you can see here the many types that can be subclassified. Thus, I do like this this quote that describes non-Hodgkin lymphoma not as a disease, for example, so on its own, or that designation itself is not the diagnosis. We really need to know what type of non-Hodgkin lymphoma someone has. Thus, patients and providers really need to know their subtype. I wanted to spend a couple slides classifying more generally what the groups might be. So often when we first think about, for example, non-Hodgkin lymphoma, we might classify them in our mind as indolent and aggressive as a first divide. Indolent lymphomas usually have a long natural history, can be 12 to 15 years plus, and certainly I have patients in my practice that have had some of these lymphomas for 20 to 30 years, and sometimes they may not have even needed treatment during that period. It's usually defined, or the natural history is that of intermittently potentially needing treatments that lead to remission. So there may be several remissions and relapses through that time that need further treatments. These kind of lymphomas can respond to many treatments and can do quite well. But over time, if some patients do have several responses and remissions, then less the remission time can become shorter with the passage of time, or with each time a treatment is needed. This is quite different from an aggressive lymphoma, where often patients have a shorter period of symptoms before they get a diagnosis, and they may present with quite acute symptoms, may present in places that are not a lymph node, such as in the stomach, the sinuses, the thyroid gland, and the treatment intent is usually with a cure. So we give more chemotherapy to get rid of the lymphoma and not have it come back, and that's sometimes may also need radiation afterwards. Many of these are B-cell lymphomas, and most of the T-cell lymphomas, and I'll define these a little bit more in the following slides, would be classified as aggressive lymphomas. So when I think about kind of subdividing the words or the category of lymphoma, we divide them, as I alluded to in the incidence slide, as non-Hodgkin and Hodgkin lymphoma. You can see here under non-Hodgkin lymphoma where most of the unique subtypes come under. There are a few subtypes under Hodgkin lymphoma, but generally they're fairly similar and have similar prognosis. But under non-Hodgkin lymphoma, we then divide the subtypes up as B-cell and T-cell lymphomas. About 80% of non-Hodgkin lymphomas is B-cell lymphoma, and about 20% are T-cell lymphomas. But then under the T-cell type, it's quite heterogeneous, and there are numerous subtypes. These are just some of the more common ones, and there are a whole host of other quite rare ones that we may only see once or twice a year, for example, even in a specialized center. So subtypes examples in T-cell would be something like angioimmunoblastic T-cell lymphoma, anaplastic large cell lymphoma, something called mycosis fungoides or Sézary syndrome, which tend to involve more of the skin. And there's actually a whole grab bag of those that couldn't be classified. They're just called peripheral T-cell lymphoma, not otherwise specified. Under B-cell lymphoma, again, we think of more clearly divide them up into aggressive and indolent lymphomas. Under aggressive lymphomas, the most common subtype would be diffuse large B-cell lymphoma. And then there are some very aggressive types, such as Burkitt lymphoma, for example. And under indolent lymphomas, we have numerous subtypes, each with a bit different clinical presentations, prognosis, and potentially treatment approaches. So follicular lymphoma, mantle cell lymphoma, and marginal zone lymphoma would be common, or the more common indolent lymphoma subtypes. When we look at how often do these occur, you can see here a few years ago, there was an update of what is seen across the U.S., for example. This is a pie, and this would be very similar to Canada, whereas these breakdowns might be quite different, for example, in Europe or some of the other, or in on other continents or in other jurisdictions. So diffuse large B-cell lymphoma is the most common type of lymphoma, looking at non-Hodgkin lymphoma. So about 25% of all lymphoid malignancies are diffuse large B-cell lymphoma. Follicular lymphoma is about 12%. You can see at chronic lymphocytic leukemia, or its designation when it's found in a lymph node, which is small lymphocytic lymphoma, is quite common as well, 20%. And then we can see some of the other subtypes are less than 10%, and some of them quite rare, such as some of the ones in this box here, like Burkitt lymphoma, about 1% of all lymphomas. And as I mentioned, Hodgkin lymphoma is much more rare than non-Hodgkin lymphoma, and it occurs in about 1/5 to 1/8 at the frequency of non-Hodgkin lymphomas. And I put this picture in here because it has this very characteristic And this is a lymphoma cell called a Reed-Sternberg cell, and these are very classic of Hodgkin lymphoma and quite pretty, I think. Another concept to be aware is that the indolent lymphomas or slow-growing lymphomas can transform to a more aggressive part, and certainly a diagnosis. As clinicians, we ask very careful questions to try to tease out if there may be a suspicion for transformation. And as we follow patients with slow-growing lymphomas, we follow for symptoms that may sound concerning for something transforming to something to more fast-growing cancer. And usually, and again, this would be going from a slow-growing to an aggressive lymphoma, so not necessarily not transforming to a different cancer altogether. So under the microscope, the tumor cells change and they go from small cells to large cells, and that's how we can tell, and the treatment implications would be quite different. The most commonly, follicular lymphoma can transform to diffuse large B-cell lymphoma, or chronic lymphocytic leukemia can also transform to, again, a diffuse large B-cell lymphoma subtype. But there are other transformation events more rarely. So, for example, chronic lymphocytic leukemia can transform very rarely to Hodgkin lymphoma. So if we suspect that this is the case, very important to try to figure out what the subtype that it's transformed to is. So switching gears, so we talked a bit about the different subtypes and how we classify them. So how do we figure out which type it is? How do we diagnose lymphoma, and what is important, or what is it important to get from a tissue perspective to feel comfortable with understanding the subtypes? So really the most important, or most of the time, we get this diagnosis on a tissue biopsy. There are many ways to get a sample of the lymph node, for example. One is a fine needle aspiration, where a liquid part of the lymph node is aspirated, and this is quite adequate for a lot of solid tumor or solid cancers, for example, head and neck cancers or breast cancer, for example, to make the diagnosis, but it's almost none of the time good enough for making a lymphoma diagnosis, because we need much bigger pieces of tissue to look under the microscope to figure out which of those subtypes it is, and to do some of the extra tests that are needed. So very important to get at least what's called a core needle biopsy, where we get a much thicker needle to get a piece of the lymph node, or really the gold standard we try to get, but is sometimes difficult, is a surgical resection, so taking out the whole lymph node. So depending on where the lymph nodes are, that sometimes can be easy, like around the neck area, but if it's in the belly area, for example, that might be quite difficult. So then a core needle biopsy is the best option, but we try to get as many biopsy needles as we can, and big pieces. So having good radiologists that can do that is really important. Sometimes we can get the diagnosis from a bone marrow test. As for some of the lymphomas, they very commonly present in the bone marrow, and very rarely, like with chronic lymphocytic leukemia, we can get it from the peripheral blood, because patients have lots of cancer cells in the blood, and there's tests we can do on the blood to figure it out, and it's quite typical. So some of the very specific subtypes, but again, for most of patients, we need a good amount of tissue to make the diagnosis. So why is, I think I've said it a couple times, but I'll reiterate it because it's really important. Pathology is important because it's needed to determine the most appropriate therapy. It requires a large biopsy, so removal of a whole node is preferred, although sometimes we have to just to have core biopsies if it's masses in the chest or the abdomen. And some of the criteria for diagnosis are very specific and lead to specific treatment choices. So for example, having a particular marker for B cells called CD20 by staining for it leads to the use of a very targeted agent, rituximab. Or if we have a patient who had a previous slow-growing lymphoma, like follicular lymphoma, and now things are growing, a lymph node is growing fast, or the symptoms have changed, to detect that transformation event I talked about, sometimes it's quite patchy. So part of a lymph node could still have the indolent lymphoma, and a part could have the transformation. So we need a whole lymph node or good pieces of it to be able to find that answer, because the treatment again would be quite different. Just to highlight some of the tests that get done on pathology, on the tissue that can highlight subtypes of lymphoma. So morphology means how do the cells look under the microscope. So that's the first thing a pathologist will do, and will be able to have a sense, are these large cells or small cells. Immunohistochemistry, you can see here this panel on the right, means staining the cells for particular markers that can tell us which type of lymphoma it might be. They can do genetic tests, and these are not hereditary tests that people pass on from parents to children, for example, but more the genetics of the lymphoma. In particular, mutations can lead to a higher risk from a chance of responding to chemotherapy, for example. And then something called gene expression profiling, which is looking at many genes in a cancer that may have changed from normal tissue to cancer, and again, different subtypes of a lymphoma might have different gene signature or different genetic signature, and that could have implications from prognosis and also for what treatments might work for this lymphoma. What else determines the outcome of treatment for lymphomas? So the type, as I mentioned, is really important. And of course, there are other factors, and I'll briefly talk about it simply to highlight that some of these factors matter more in some subtypes than others. So things like age, performance status, what stage it is, how big the size of the lumps are, so the bulkiness. If there's what we call extranodal disease, so it's disease outside the lymph nodes, so in the liver or the lungs, for example, and the treatments we give do matter, of course. So how do we stage lymphomas? Physical examination can still be important in terms of feeling for lymph nodes. Traditionally, CAT scans have been the way to look at where the lymph nodes are in the body and how big they are, so of the head and neck, the chest, and the belly. However, this has been enhanced by the addition of a PET scan, and now we do PET scan and CT scans together. And a PET scan is giving a sugar solution that lights up where lymphoma is, and it's quite good for most lymphomas in telling us where in the body the lymphoma is, and particularly in some of those extranodal sites, so the bone marrow, the lungs, the liver, it can be very helpful. So most patients will have a PET scan with CAT scans at diagnosis. There are some indications where looking halfway through with a PET scan is helpful, so in Hodgkin lymphoma, and at the end of treatment, this will be performed, and it's very good at telling us whether we've gotten rid of all the lymphoma, and particularly if the PET scan is negative, where we feel very confident that we've gotten rid of most of the lymphoma. If there's still some PET positivity, there's still some, it's still lighting up a bit, it doesn't necessarily mean there's still lymphoma there, as there are numerous causes for false positivity, and at that point the oncologist would decide what the next steps are depending on how it looked. Staging of lymphoma is based on where it is in the body. Stage 1 is where there's one site, as seen here, for example, one lymph node area in the neck. Stage 2 would be more than one area, but it's either above or below the diaphragm, so that's the the cutoff. Stage 3 would be lymph nodes above and below the diaphragm, and stage 4 is where there are extranodal sites, so for example in the liver or the bone marrow, which is what the pelvis represents here. However, very important to point out, and I highlight this for patients all the time, that stage 4 disease in lymphoma is can be quite different than in other cancers such as lung cancer or colon cancer, in that we still have a very good chance of treatment response, whether it's cure with a more aggressive lymphoma or putting it in remission or getting rid of it with slower growing lymphomas. Because this is a cancer of the immune system and of the blood, so it's not unusual for us to see lymphoma in numerous spots, and thus again, from a treatment perspective, the prognosis of stage 4 lymphoma can still be quite good. Just wanted to show here what a PET scan looked like, and there are criteria for looking. So there's some brightness here. This is highlighting the liver, the kidneys down here, with the sugar solution, and how positivity and negativity gets red is dependent on how much the lymph node, for example, lights up compared to some normal tissue, because some of the normal tissues in our body will take up the solution used in the PET scan. Bulky disease is defined as having a particular size of a mass, and depending on the subtype of lymphoma, that definition can be a little bit different. In some it's 10 centimeters, in some it's 7 centimeters. And then we often ask about and consider that having what's called B symptoms is important in lymphoma. So having a particular amount of weight loss, unexplained fevers, and drenching night sweats can have some meaning. And we always want to define these symptoms well, because people can have so being warm at night or having some sweating around the neck, for example, would not count as or would not likely be related to lymphoma, whereas drenching night sweats, I usually think about or ask about people having to change their clothes or change their bed sheets at night. So really quite significant sweats would be what would be significant. And this is what a PET scan would look like before and after treatment. So you can see here that there are many black spots throughout the body, and that would be involvement by lymphoma, these ones here. And then we can see at the end of treatment, there wasn't very much. Most of that is gone. The black part here is the heart, so that would be normal. So that would be the kind of response we would hope for after treatment. And before treatment, it helps us understand the burden of disease throughout the body. So with that part, I've highlighted what the subtypes are, why it's important to get a good amount of tissue to look at the pathologies, and then from a staging perspective, those are some of the tests we do to understand where in the body the lymphoma is. Most of the time, again, this is with these days at the diagnosis, it's with the PET-CT. We can get information from the blood. A bone marrow aspirate and biopsy, I didn't speak too much about it, may still be part of the staging process in some patients, but it's becoming less and less needed now that the PET scan can really give us a good sense of where the lymphoma is in the body. So I'm now going to move on to just give a few subtype examples to highlight the differences in how we would treat a patient and what the prognosis and follow-up would be like, or what treatments would be available down the line if the first-line treatment didn't work. And again, this is to highlight why it is important to know your lymphoma subtype. So first, just a few points. Again, I think I've tried to iterate this so far. We'll say it a couple more times before the end. that the different subtypes can have different clinical courses, different treatment options are available, and different prognoses in terms of outcomes and survival are implied by applied to the particular subtypes. Thus, knowing this, I think, as a patient can help you set appropriate expectations for your care, feel confident in your decisions related to your care, and knowing what to expect and what questions to ask, and thus help you prepare the right types of questions to ask your physician. It can help you connect with other patients with similar lymphoma subtypes, and helps you self-educate and self-advocate for the appropriate treatments for you. So I'll start with the most common type of lymphoma, diffuse large B-cell lymphoma, which is a type of aggressive lymphoma. This is the most common aggressive lymphoma, as I mentioned, and the incidence is about 4 patients per 100,000 people per year. And in the Greater Toronto area, we might diagnose about 240 patients per year. The median age is 65 years of age. About a third of the patients present with localized disease, so in just 1 or 2 parts of the body, so the stage 1, 2 I highlighted before, and about 2/3 of patients have advanced stage disease, so stage 3 or 4. The standard treatment is with a chemotherapy recipe called CHOP, with the addition of a drug called rituximab that targets a specific marker on B lymphocytes, including B-cell lymphoma cells called CD20. And this type of lymphoma is curable in about 60 to 70% of patients. There are some easily available variables that can help us categorize patients a little bit more in terms of the chances of doing well with chemotherapy. So age is important, stage, so whether it's stage 1, 2 or stage 3, 4, performance status, so how sick is a person when we first meet them, number of extranodal sites, so those are again the sites outside of the lymph nodes, and a blood test called LDH. And out of 5, having 0 versus 5 of these factors would mean having a very good chance of responding to therapy versus the chances being a little bit lower, still reasonable, but not as good as if you had none of these risk factors. However, there are newer ways of looking at diffuse large B-cell lymphoma, and this is important information we gather from the pathology specimen. So there are some proteins that get expressed by the lymphoma cells, something called c-MYC and something called BCL2, and these, when turned on, stop the cancer cells from dying. So, and our goals generally for the cells in our body and for cancers, of course, for cells not to continue to grow. And having both of these expressed together is a intermediately bad problem, and it's called dual expressor. There also can be chromosome or genetic changes that occur in the lymphoma cells, and having a mutation in this gene, the c-MYC or the BCL2 gene, is also particularly bad, and having both of them happen defines what's called double hit lymphoma. And when the lymphoma has this signature, our chances of curing it with the chemotherapy we have is significantly lower. And this is information that we get from the pathology specimen and tests that the pathologist will send on the tissue to better understand the subtype of diffuse large B-cell lymphoma. So we know, again, having neither of these problems, the c-MYC or the BCL2, as an expressor of the protein or as a gene mutation, gives the best outcomes. If you have the dual protein expression is less good, and having the dual translocation or this double hit lymphoma generally poor. Certainly our chances of getting rid of it are much lower. So it's information we want to know when we first start out. Thankfully, it's still a minority of patients. Only about 5% of DLBCL patients will have the double hit changes. However, for most patients, the current standard would be 6 cycles of the R-CHOP chemotherapy. So these are 4 intravenous drugs, the rituximab, cyclophosphamide, vincristine, and doxorubicin with some steroid medication. And this is given for 4 to 6 cycles, depending on the stage. And there may be radiation afterwards, depending on, again, stage and the bulk of the disease. For double hit lymphoma, often we think about giving a more intensive or a bit of a different chemotherapy recipe called dose-adjusted R-EPOCH, which is still a bunch of intravenous drugs together, but given a little bit differently over 5 days rather than just 1 day. So again, having that information is important for choosing the treatment. Most patients with aggressive lymphoma, if things go well and go into remission, will be followed every 3 months for the first 2 years. Then it might stretch out a little bit if all is well, every 6 months for a 3rd year, then yearly for up to year 5. And if all is well at that time, depending on what else is going on and how the treatment went, there's a potential to be referred back to a family physician for ongoing yearly regular follow-ups as considered cured in most cases. I just wanted to highlight a couple of, an exciting new treatment in diffuse large B-cell lymphoma that's particularly right now approved standard of care for this subtype. So again, that's why we want to know that we're treating the right thing. So if the lymphoma does come back, we think about further treatment options. Sometimes it would mean more chemotherapy and a stem cell transplant. And if that doesn't work, an exciting treatment that is now approved for diffuse large B-cell lymphoma is something called CAR T therapy. And this is a different way of treating cancer, which is programming a patient's own T cells to recognize the cancer and kill it. So it's quite an involved process where a patient has their T cells collected, so a different part of the immune system, and they are manufactured or manipulated in the lab to be able to recognize the lymphoma cells based on a particular target. And so that takes about 3 weeks to be manufactured, and then they are infused back into the patient. And there's a good chance that when chemotherapy wasn't able to kill the lymphoma anymore, then now this supercharged immune system can fight the lymphoma. Our immune system should know that as human beings that when there's something foreign or something bad in our body to try to fight it. That's what it does with viruses or with other bacteria. However, cancer is tricky and has figured out ways to hide from the immune system or to exhaust it or confuse it. And this treatment and many other treatments that are coming up now in cancer in general are looking to reactivate or to supercharge the immune system to fight the cancer, in this case lymphoma, when it's been tricked by cancer and put to sleep a little bit. So this works well in lymphomas, and right now it's again standardly approved for diffuse large B-cell lymphoma, and we've been treating some patients with that if they're eligible and appropriate candidates. And it is being developed and studied in some of the other lymphomas, including the indolent lymphomas, but in some cases it's still under being studied, or it may not work as well in slow-growing lymphomas as it does in an aggressive lymphoma, for example. And this picture just reiterates a little bit of what I showed before, where you have this is the immune system cell that's now been designed to recognize that there's this target CD19 on the lymphoma cell, and it attacks it and kills it. And this algorithm highlights what I pointed out before, that Previously, after we went through a couple lines of therapy, when patients had relapsed DLBCL, the outcomes were quite poor, and palliative care was often the route we had to take. But now we have new therapies in this subtype that are very promising and can still offer good outcomes for a proportion of patients. So moving on to the other side of the spectrum, indolent or slow-growing lymphomas, I'll highlight follicular lymphoma, which is the most common slow-growing lymphoma and can have a very different natural history than aggressive lymphoma, for example, can be quite extended. Patients can be asymptomatic for many years without needing any treatments. And our goals of care really are to maximize quality of life, as for most patients, we cannot cure these lymphomas, but we can keep them in remission or keep them quiet and not causing problems for many, many years. Thus, the treatment of this subtype is incurable, except if a limited stage, which is a minority of patients. However, responds very well to initial therapy, can transform to aggressive lymphoma, and then treatments would be different, more as I highlighted in the previous slides. And the median survival can be well over 20 years, and it's increasing as we get more and more treatments. The grading of follicular lymphoma can be important for how we treat it, and this has to do with how it looks under the microscope, how many the centroblasts are kind of larger cells that can be seen when the pathologists look at a specimen. And having, for example, grade 3A versus grade 3B can mean different treatments, and grade 3B is often treated as the same as the diffuse large B-cell lymphoma or as an aggressive lymphoma. And I highlight this mainly to, again, point out the importance of tissue, because we need a whole lymph node or a good piece of a lymph node to be able to properly tell this grading, and for the pathologist to be able to tell. So again, the importance of getting a good amount of tissue for lymphoma diagnosis. Stage 1 to 2 patients often will have radiation to the area, and this can keep the disease in remission for a very long time. And so this is different than having stage 1 to diffuse large B-cell lymphoma, for example, where chemotherapy is always a part of the treatment, or most often in follicular lymphoma, it may just be radiation. And for advanced stage patients, which is the majority of patients, we actually know we don't have to give chemotherapy or treatment unless it's causing symptoms. And so these are some of the indications for giving treatment in follicular lymphoma. So having low blood counts, having a large amount or larger lymph node masses, fluid around the lungs or abdomen, or having the B symptoms we talked about. And follicular lymphoma is treated with quite a different chemotherapy regimen. Bendamustine and rituximab are 2 drugs that have been shown to be better than R-CHOP chemotherapy, the treatment given for aggressive lymphoma, and this is given for 6 cycles. And then rituximab, the immunotherapy, is given as a maintenance in most patients for up to 2 years. And it improves outcomes in follicular lymphoma patients, but not in aggressive lymphoma patients. So it's really quite subtype specific. And then patients are often followed every 3 to 6 months ongoing. And in my practice, for example, I keep patients remain in my practice ongoing, so not usually discharged back to a family physician, as there is the chance that down the line, even 5 to 10 years down the line, that it could come back and require more treatment. And finally, I'll finish up with a few slides on the counterpart of non-Hodgkin lymphoma, which is Hodgkin lymphoma, quite different. And the patients who get Hodgkin lymphoma are quite different, but however, sometimes, again, depending on the subtypes, it can be difficult to tell between particular subtypes of non-Hodgkin lymphoma and Hodgkin lymphoma on pathology, and we need, again, a good amount of tissue to be able to tell. Hodgkin lymphoma is a disease of young patients. So, the peak is really in kind of the 15 to 35 age group, but there is another peak that occurs later on in life for patients in their 60s and 70s. There are markers on the cells again that are quite characteristic, and CD30 is a really important one because there are treatments that can target CD30. This slide is simply to highlight that there are a couple of subtypes that can be quite different, something called classical Hodgkin lymphoma, which is the majority of Hodgkin lymphomas, but another subtype is a nodule lymphocyte predominant Hodgkin lymphoma. I know a mouthful of words, but that has a very different look, or the markers on the cells are quite different, so that the treatments that we would apply to these two subtypes can sometimes be quite different in terms of the chemotherapy recipes. And this can be quite difficult as a diagnosis to make or to categorize without, again, having a good amount of tissue for the pathologist to be able to have a good look at the cells. Hodgkin lymphoma treatment, for example, is quite different than the other lymphomas we talked about. Over the many years, it's tried to achieve a balance between too much treatment and the toxicities, especially as often patients are young, so giving radiation and giving chemotherapy can have long-term side effects. And in Hodgkin lymphoma, we've learned earlier on that using PET scans, for example, after a couple cycles of chemotherapy, can help us decide what to do, how to give more treatment, who needs more treatment, and who can have a reduction to minimize those long-term side effects like infertility and secondary cancers. And limited stage, just highlighting what the treatments could look like for a Hodgkin lymphoma patients, for example. Often we use a recipe called ABVD, which is 4 different intravenous drugs that some are similar to the CHOP recipe, for example, but a couple of drugs are different. And for limited stage patients, so having stage 1 or 2, they will get 2 cycles of chemotherapy, have a PET scan, and then depending on whether the PET scan is positive or negative, the treatment could escalate to more chemotherapy or different cycles of chemotherapy or having radiation. And similarly, in advanced stage patients, the treatment options are several, and certainly not the purpose of this talk, but to highlight that there are a couple of recipes we can give, and also new drugs, and a drug called brentuximab vedotin that targets CD30. So that marker I highlighted at the beginning is now starting to be integrated into the treatment approach. So, so again, knowing exactly what type we're dealing with and what the markers on the lymphoma are can be very important for picking and adapting therapies. I just wanted to, again, highlight some of the new treatments that are helping us improve outcomes in lymphoma, and again, can be important from a from knowing whether the subtype can be important. So brentuximab vedotin targets CD30, which is a marker again on Hodgkin lymphoma, but can be a marker on other lymphomas as well, such as T-cell lymphomas, and now is part of the treatment algorithm for these lymphomas. Another immunotherapy that has been very exciting and is a similar concept to what we saw with CAR T therapy is where we know that the T cells, which is the normal immune system, again should know that a tumor cell is foreign and is bad and should try to kill it. But there's these interactions between these markers on the 2 cells that causes the T cell to ignore the tumor cells. So again, the tumor cells become sneaky in developing this marker. So this particular drug called the PD-1 inhibitor goes in between this interaction, so disrupts this interaction. So now the T cell wakes up and realizes this is a tumor cell, and this leads to tumor cell death. And this has been a very successful treatment in Hodgkin lymphoma, and is being tested and has activity in other non-Hodgkin lymphomas as well. And these are some markers. These markers can be tested on the tumor cell. And again, important for us to understand what particular subtype of lymphoma it is, and whether these treatments would be useful for in patients. So in conclusion, I hope I've convinced you and reiterated a few times that lymphoma is not really a disease on its own, or encompasses many different types, and it's the subtypes really that define the disease and the prognosis and the treatment, and that the prognosis treatment options in frontline, and if it comes back, can be really quite different depending on the subtype, especially with all these new exciting treatments being developed that can be quite specific to the particular subtype. Even within each subtype of lymphoma, so when we talked about diffuse large B-cell lymphoma, and then that really poor subtype double hit lymphoma, there can be subgroups that have differing features and prognosis. So really having a good amount of tissue for proper pathology evaluation is crucial, as is having a pathologist that has experience in lymphoma and can help with these with a difficult diagnosis at times. So how do you find out your lymphoma subtype? Certainly during your diagnosis, you undergo different tests to confirm what it is, and the pathologist will usually record it on the pathology report if you underwent a biopsy. However, if it's not a good enough tissue, or if they don't have enough, sometimes they do have to say that they suspect a particular subtype, or they say yes, it's a small cell non-Hodgkin lymphoma, but they can't tell more than that if there's not enough tissue to do all the tests they need to do. Your doctor and your oncologist should tell you your subtype of diagnosis. If they do not, be sure to ask them. And if you do not remember your subtype, do ask your hematologist or oncologist again, as again, the resources you access or the information you look for may be is quite specific to that. So how to find out more information, prepare a list of questions to ask your physician. Lymphoma Canada has important resources, and you'll hear a little bit more about this at the end. The hospital website or the provincial cancer care website, so Cancer Care Ontario, has information on this, and you can look for published research articles, although that can be quite complex. And be wary of general internet research and sources, as this information may not be reviewed by a doctor or may not be Canadian specific, or again specific to your subtype. So I'll stop there. I think I went a few more minutes than I meant to, but hopefully we have some time for questions, and then Caitlin will highlight a couple of things at the end from a Lymphoma Canada perspective. Thank you very much for your attention.
Wonderful. Thank you so much, Dr. Fika. That was a really wonderful presentation. Thank you for sharing with us some different types of case examples for different lymphomas, and just showing how they can really drastically differ throughout their clinical course. So this helps provide a bit of insight as to why it's important to know your lymphoma subtype. Thank you as well for providing more information for patients on how to learn about their lymphoma subtype from their care team, and how to find out more information specific to their lymphoma. There are so many resources out there for patients, specific as well to different subtypes. So it's important to know that these do exist and how to access them. Just a reminder for those who have joined us live today that you can still type in your questions into the control panel on your screen, and we will try to get to them all. We do have quite a couple questions to get through, which is great. So we'll start off right now. You had mentioned really importantly about asking your doctor about how sure they are of the diagnosis. And so in the scenario where the doctor might be unsure, you said it might be related to maybe not having enough tissue to perform biopsies or different tests on. In that scenario, would a patient then have to undergo additional testing to try and get a confirmation of their diagnosis?
Yeah, so that's an excellent question, and certainly I don't, the likelihood of that is really quite dependent on the particular case and the urgency of starting treatment. So often, as physicians, we have to balance if patients or someone is unwell, and so we may have, I've highlighted some features that we really try to get, but if we don't, sometimes we may not necessarily think it'll change the immediate treatment we need to start. So so we often have to, if we have it, we may have enough information, or in putting the picture together, feel like, okay, this really looks like diffuse large B-cell lymphoma, even though it wasn't as clearly stated in the pathology report. So so it is a, I guess, a marriage between the clinical information and the pathology information, and then deciding on whether enough, there would be sort of further details that would be useful from another biopsy, balanced with the delay in starting chemotherapy that would imply, for example. Or in some cases, it might be just really difficult to access more tissue. So if it's a particularly difficult site, and it already took you know, a couple biopsies or a surgeon, etc., to get to it, sometimes we have to just make that decision to go with what we have. But I think it's always worth asking the question and having that discussion with the clinician.
Great, thank you so much. The next question we have, and you touched on this a bit in your presentation, is if a lymphoma transforms from an indolent lymphoma to an aggressive lymphoma, can it ever transform back to that indolent lymphoma? And will your clinical care be a combination of the two types of lymphoma, or just kind of moving more towards the aggressive subtype as that decision to decide future treatment and care?
Yeah, that's a very good question, and the answer really is that you still remain with both, I guess. So so the indolent lymphoma usually will remain as a diagnosis, so it's not so much that the aggressive lymphoma transforms back, but we think there's still sort of indolent lymphoma through some parts of the body, and one part of it may have transformed to aggressive lymphoma. When we give treatment, thankfully, most of the chemotherapies we would use for aggressive lymphoma would still treat the indolent lymphoma as well. So our aim is to cure the aggressive component. The indolent component will likely be treated, but then the monitoring would still be the same as an indolent lymphoma, and we think down the line it may come back as it would have even if there was no aggressive transformation. So yes, I guess the answer is that the approach and the treatment would be to treat both. The urgent part usually is the aggressive component, but the follow-up will be for the indolent component as well.
Okay, great. Thank you so much for clarifying. We have still a few questions coming in, which is great. The next question is, are there still new lymphoma subtypes that are being discovered and classified, I guess you could say?
I would say the answer is yes. It seems with each iteration, as there's more molecular and genetic information about the different subtypes, more subcategories do. So they're not necessarily new, I guess. Probably they were lumped in as a more generic category before, like T-cell lymphoma, not otherwise specified, and now we might be able to subcategorize them further as we learn more and more about their molecular and genetic subcategorization, and it might help us with, as more targeted treatments are coming. That is important information that hopefully down the line will allow more personalized or precision treatment from that perspective.
Okay, great. Thank you. So it looks like we have time for just one last question very quickly. I just wanted to clarify with you, and I know you had presented throughout your presentation, maybe touched on this a couple times, and whether there are some lymphoma subtypes that are curable with treatment, and whether there are others that are not, and why does this difference exist?
Yeah, so absolutely there are curable lymphomas, and by that we mean that with the chemotherapy we think we've gotten rid of all of it, and it won't come back, and those are mostly the aggressive lymphomas. And the slow-growing lymphomas, we believe that they're incurable with most treatments we have so far, and that probably has to do again with the biology of the lymphoma, where they're so slow growing that the chemotherapy can kill most of it, but there may be small amounts of very sleepy lymphoma cells that are hiding somewhere and are not killed. Like chemotherapy kills faster growing cells better than it kills slower growing cells, at least traditional chemotherapy. So there will be, the belief is there are, again, these sleepy lymphoma cells that are hiding somewhere, and at some point, whether it's in 5 years or 15 or 20 years, depending on how long someone lives, they have a chance of coming back. That might change. So with, we're wondering if with CAR T therapy, for example, that could, will that offer cure for indolent lymphomas, for example? We don't know yet. It's too early to be able to tell, but that will be some of the information we'll, be able to figure out in 5-10 years down the line.
Okay, that's wonderful. Thank you so much for answering these questions. I know we had a couple more questions coming through, but I think we've just about run out of time for today. So if you wouldn't mind kindly just flipping to the next slide. Before we head out today, Lymphoma Canada would just like to make an exciting announcement. On the heels of this presentation, we would like to let you know that we will be releasing our subtype fact sheets, and these provide detailed information for patients related to all aspects about their clinical course, such as symptoms they might experience, diagnostic testing and procedures, staging and prognosis, treatment options, and follow-up care specific to the lymphoma subtype in question. As iterated throughout this presentation, knowing your lymphoma subtype will of course allow you to continue with your own self-education and self-advocacy for your care where it might be needed. It can also help you set appropriate expectations as you move through your care and feel confident with your care decisions. And it can also help you to connect with other patients with the same subtype and learn about their experience and what they've gone through as well. If I can ask you to click to the next slide. Wonderful. So with the help of our scientific advisory board and clinical specialists across the country, such as Dr. Frika, we've actually developed 14 subtype fact sheets related more so to the more common subtypes of lymphoma that you tend to see. These will be released relatively soon. If you are part of our mailing list, you'll get an email through this. Otherwise, if you are not, you can access these directly through our website. We are very excited to share these fantastic resources with you and hope they provide you with a bit more information and guidance throughout your lymphoma journey. Before we head out for the day, I just wanted to take a moment to thank Dr. Frika for taking the time to share your expertise with us today. As well, I want to thank everyone who was able to join live in the audience. If you do have any follow-up questions, or if we were unable to answer your question live today, please reach out to us via email for more information to info@lymphoma.ca. As a reminder, we will be posting this recording on our website to use as a resource, and please feel free to watch it again if there was maybe something you missed, or if a family, friend, or colleague was unable to join, they can of course then watch this at their convenience. You will also be sent an email this evening with a link to watch the recording. We hope you learned a lot from this presentation. Of course, continue to use Lymphoma Canada as a resource for education and support. You can watch the recordings for all of our webinars on our website by going to lymphoma.ca and accessing the educational webinars and forums page, which is located under the resource tab. As a final thank you, we greatly appreciate your time and expertise, Dr. Frika. Thank you for informing the community about the importance of knowing your lymphoma subtype and how to access this information. And of course, thank you to our live audience today. Hope you all have a wonderful afternoon and stay safe. Bye now.
Thank you. Bye.